The following podcast is part of a certified educational activity titled Finding the Heat in Cold Tumors, Potential for Perioperative Immunotherapy Strategies in Early Breast Cancer. Access the entire activity and complete the post-test at peerview.com/HKW860. Downloadable slides and practice aids are also available.
Welcome everyone to this PeerView in Exchange program today. We're focusing on the finding the heat in cold tumors and want to discuss with you today the potential for perioperative immune therapy and strategies in early breast cancer. I'm Peter Schmidt. I'm a medical oncologist. I work at Barts Hospital in London. And it's a true pleasure for me to be joined by two dear colleagues and friends, Carmen Criscitello from the European Institute of Oncology in Milano and Javier Cortés from the International Breast Cancer Center in Barcelona. Our goals for today are to review the knowledge of the latest evidence on immune therapy in early triple-negative breast cancer, but also the emerging evidence in early ER-positive, HER2-negative breast cancer. We also discuss how this has already been implemented in guidelines, and we ultimately want to equip you with skills for devising individualized care plans that can incorporate immune therapy for patients with early triple-negative breast cancer and hopefully in the future also for ER-positive, HER2-negative breast cancer. Our agenda today will start with Javier Cortés, who will talk about advances in immune therapy in early-stage triple-negative breast cancer. The second part will be Carmen, who will talk about progress with immune therapy in early-stage ER-positive, HER2-negative breast cancer. And we will leave plenty of time at the end for a joint discussion about the controversies and where we're heading with immune therapy in early-stage breast cancer. So it's my pleasure now to introduce Javier Cortés, who will speak about advances with immune therapy in early-stage triple-negative breast cancer. Javi, over to you.
Very much, Peter, Carmen. Thank you very much, PeerView, also for inviting me to be here. It's always tricky or a challenge to talk about this topic in front of Peter Smith, who is clearly one of the top experts in the world and also the lead author and the genius mind about the design of this study. So, Peter, apologize if you disagree with something. Absolutely happy to discuss afterwards during the Q&A session. But of course, it's my great pleasure to talk about this important topic. We have clearly now changed the standard of care, and we are able to help many more patients compared with past years. And we are curing more and more patients with immunotherapy in this tumor type. So what are the goals of neoadjuvant treatment in breast cancer? I think we have plenty of reasons to discuss neoadjuvant approach before surgery. But I would like to highlight, at least in triple-negative breast cancer and the HER2-positive tumor, in my opinion at least, one of the most important reasons to consider neoadjuvant treatment, which is to improve disease-free survival and overall survival using pathological response to discuss how to optimize the adjuvant setting. We all know that PCR clearly correlates with event-free survival and also overall survival in triple-negative breast cancer, also in other tumor types, maybe in HER2-positive and in high-risk hormone receptor-positive tumors, but clearly in the TNBC field, PCR, those patients who achieve PCR will have many more chances to be cured compared with those patients who unfortunately do not increase or do not have a pathological complete remission. So the first question we can ask ourselves is how can we increase pathological complete remission? And we have been discussing the role of platinum compounds for a great number of years, and it continues to be a debate, maybe for some physicians. In my opinion, it should finish based on the last data we have. It is true that the great majority of the randomized trials, phase 2 or phase 3, looked at PCR at the primary endpoints. And here we have three important trials, GEPAR-6, CLGB, 4063, and BRAINESS, showing that when we combine chemotherapy with platinum compounds, we clearly improve pathological complete remission. And it is true that in the majority of these trials also we observed a clear improvement in long-term outcomes in event-free survival or disease-free survival. There are other two trials, ATA-TMC and the PERLY trial that was presented at ASCO 2024, that the primary endpoint was event event-free survival. And I think this is very important basically for the PeerLead trial, that this trial was positive for this primary endpoint. When we combine chemotherapy plus carboplatin, we improve clearly event-free survival. So in my opinion, carboplatin added to chemotherapy, taxane plus anthracycline-based therapy should be, at least for a great majority of patients, be offered to this group of patients. So what about immunotherapy? In early triple-negative breast cancer, we have plenty of studies looking at the role of immunotherapy. To the best of my knowledge, there are 4 randomized phase 3 studies, 2 of them large studies, KEYNOTE-522 and ACPE-B59 or GERPAR-2, that have been presented at San Antonio this year. And there are 2 other trials, which are smaller, NeoTrip and Impassion 031. The point with the NeoTrip trial is that, in my opinion, the control arm is not standard. So I don't know how to consider the results of this study. But regarding KEYNOTE-522 and Impassion 031, there was positive PCR improvement when immunotherapy was combined with chemotherapy. So this is KEYNOTE-522, maybe the most important randomized phase 3 study with immunotherapy in this setting. Just 3 or 4 key messages for this study. Patients with stage 2 and stage 3 triple-negative breast cancer were included. The chemotherapeutic backbone was, in my opinion, the best chemotherapy strategy we might expect. Platinum compounds plus taxanes, paclitaxel in this case, followed by AC or EC with either pembrolizumab or placebo, followed by surgery, followed by pembrolizumab or placebo. And the third key message here is that the primary endpoints were pathological complete remission and long-term outcomes, disease-free survival. What did we have from these 2 primary endpoints? We know that the first data that was presented by Peter and published in the New England Journal of Medicine showed that when we combine pembrolizumab plus chemotherapy, we improved pathological complete remission, about 14% absolute benefit at that time, but also we improved event-free survival with a hazard ratio of 0.63. And based on this data, immunotherapy with pembrolizumab was approved at least by the EMA and FDA, but also with other regulatory agencies. One of the key aspects that were presented some time ago in San Antonio 2019 was the role of the PD-L1 expression in adding pembrolizumab to chemotherapy. We all know that PD-L1 expression is an important biomarker to be considered in the metastatic disease, but in the early breast cancer, it does not play a role to decide who patients will need or not immunotherapy. You can see on this slide that regardless the expression of PD-L1, all patients benefited more or less the same of adding pembrolizumab. Why is this? Why do we think that PD-L1 might play a role in the metastatic setting, but clearly not in the early breast cancer scenario? We have 2 beautiful data. These are data coming from Gianpaolo Bianchini, showing basically that the tumor seems to be quite dynamic. So once we start, in this case with chemotherapy plus atezolizumab, just after 1 cycle, there is about 2/3 of these tumors which moved from PD-L1 negative to PD-L1 positive. This data came from the NeoTrip trial. So the dynamic of the tumor microenvironment might, at least in some way, explain why both PD-L1 positive and PD-L1 negative tumors might benefit from the addition of immunotherapy. And there is another important study, which is called Eclipse, led by Peter, presented at San Antonio 2020, that there was a beautiful study exploring different biomarkers. But from now, look at the first figure. Same data as before. Those patients who received, again, atezolizumab with different strategies, doesn't matter now, 2/3 of these tumors changed from PD-L1 negative to PD-L1 positive. So in my opinion, at least, one of the explanations is that the plasticity of the tumor, of the microenvironment, might, again, explain why immunotherapy might work in both PD-L1 positive and PD-L1 negative tumors. At ESMO 2024, Peter updated the data of Keynote 522, recently also published in the New England Journal of Medicine, with important results. The first one, here we have the updated event-free survival curves. Hazard ratio, 0.65. It seems to be a plateau after 4 to 5 years, but the absolute improvement was in the range of 9% at 5 years in favor of those patients who received pembrolizumab. What about the subgroup analysis? As we can observe here, we cannot identify any groups of patients who will not benefit from the addition of pembrolizumab. Of course, there is in the age of higher or older than 65, take into account the very low number of patients included there and the large confidence intervals. So in my opinion, all patients could benefit from the addition of pembrolizumab. Important analysis that was presented at ESMO a year ago was the event-free survival by pathological complete remission. And you can compare here the first analysis at the interim analysis 4 and the interim analysis 6. What can we observe? Those patients who did not achieve PCR clearly benefited if pembrolizumab was added compared with chemotherapy, but also in the longer follow-up assessments, the interim analysis 6, those patients who achieved pathological complete remission but also received pembrolizumab did have 4% absolute benefit in event-free survival compared with those patients who achieved PCR but did not receive pembrolizumab. So very, very important results that we put into the context afterwards talking about overall survival. Also, Peter presented at ESMO important data, maybe some of the most important secondary endpoints, which was overall survival. As expected, with a longer follow-up, those patients who experienced progressive disease unfortunately died after 1, 2, or 3 years. This is why, at this time, we also observed an overall survival improvement. You can see here an impressive hazard ratio of 0.66 in favor of pembrolizumab, absolute benefit in the range of 5% at 5 years. So pembrolizumab not only cure more patients, also improve survival. What about subgroup analysis in terms of survival? So as expected, again, all subgroup analysis, this subgroup analysis showed that all patients benefited the same from adding pembrolizumab compared with those patients who did not receive pembrolizumab. This slide, I think this is a very important analysis. We can observe that in terms of overall survival, again, those patients who did not achieve PCR did have better survival if pembrolizumab was added. But for those patients who achieved PCR, overall survival was 94% at 5 years if no pembro, and 95% if pembro. So we can argue that maybe we should not go for pembrolizumab if we had a pathological complete remission. Let me discuss a little bit why, in my opinion, this is not fair. And let me compare the PCR for event-free survival and for overall survival. What can we observe here? In those patients who did not achieve PCR, the great majority of events occurred during the first 2 to 3 years. So unfortunately, these patients die in the next 2 to 3 years. So this is why, again, in my opinion, in the 5-year analysis, we observed an important number of patients who died. And of course, if we had less events with pembrolizumab, we have had less events for survival with pembrolizumab. However, when we are analyzing PCR, some of the events occurred quite late in the time of the disease. Some of them maybe 3, 4, almost 5 years after surgery. So these patients will need more time, unfortunately, again, to die. That's why, in my opinion, for those patients who achieve PCR, maybe 2 or 3 more years, we will see these results, these differences also in survival. Another important data that have been presented at San Antonio this year by Rebecca Den was the subgroup analysis in terms of survival. What happened with those patients with T2 and 0? We can see here that the hazard ratio was 0.51 in favor of pembrolizumab. So for stage 2 but tiny tumors, we also, in my opinion, should offer pembrolizumab to improve not only event-free survival, but also overall survival. One other important analysis that was presented at San Antonio 2024 was the biomarker analysis. I invite you clearly to review the data that was presented, but let me make just 2 comments today here. The first one is that it was an impressive signature with 18 different genes associated with the immune system, and we can observe that this immune signature correlates with both PCR and event-free survival in both groups of patients, pembro-treated and placebo-treated. Also, tumor mutational burden was explored, and as you can observe on this slide, there was a positive association for both PCR and event-free survival in the pembro arm, but not for event-free survival in the chemo arm. Let me show you now some Kaplan-Meier curves. You can see here that when we look at the event-free survival according to the signature, we can observe that both groups, higher and lower, benefited more from pembrolizumab compared with placebo. And regarding TMB, the higher the TMB is, at least with a cutoff of 175, we can see the terrific improvement when immunotherapy with pembrolizumab was combined to chemotherapy compared with chemotherapy alone. 2 comments about adverse events. The first one is that all grade 3-5 or any grade treatment-related adverse events were basically very similar between both groups of treatments, patients treated with pembro and with placebo. However, I think it's obviously, when we look at the immune-related or immune-mediated adverse events, those patients who received pembrolizumab did have more immune-related adverse events compared with those patients who did not receive immunotherapy. Nevertheless, which were the most important adverse events associated with pembrolizumab? Basically, hypo and hyperthyroidism. One of the important comments that have appeared many times is about the role of adjuvant pembrolizumab in the Keynote 522. I'm going to make 3 comments here. The first one is that Keynote 522 is a total strategy, neoadjuvant, surgery, and adjuvant chemotherapy, and adjuvant pembrolizumab, and with this strategy, we improve event-free survival and overall survival. We have data with immunotherapy just in the adjuvant setting, Alexandria or Impassion CO30, showing that atezolizumab just in the adjuvant setting did not improve outcomes, and data coming from the ABRAVE, which combined 2 groups of patients. Patients who received adjuvant chemo with or without avelumab, no benefit at all, and patients who received neoadjuvant chemotherapy, no PCR, and continue with avelumab or observation. And it seems that there is a trend, at least, to improve outcomes for this group of patients, which were about 20 to 30% of the total population. Finally, there is a beautiful study in melanoma patients showing that when we give pembrolizumab before surgery and after surgery, it seems to have more benefit than adding pembrolizumab just in the adjuvant setting. In my opinion, and I think that I echo with the ESMO guidelines said, I think that for stage 2 and stage 3, pembrolizumab in the neoadjuvant followed by the adjuvant setting has become the standard of care. We have, again, to improve the outcome of those patients who did not achieve pathological complete remission. We need more clinical trials. Maybe new antibody conjugates could help these patients in this situation, and also how to optimize the treatment in the tiny tumors, T1A, D, and C. Can we maybe look at biomarkers to de-escalate treatment for this group of patients? So many questions to be answered, and many more data will come in the next future. Thanks very much again, and looking forward to listening to Carmen and the discussion afterwards. Thank you.
Thank you, Javi. Fantastic presentation, really comprehensive oversight on where we stand with immunotherapy in triple-negative breast cancer. We will discuss this together after the second presentation. But before that, I would like to hand over to Carmen from Milano, who will talk about the same topic, immunotherapy, but this time focusing on patients with early-stage ER-positive, HER2-negative breast cancer. Carmen, over to you, please.
Thank you, Peter. Thank you, Harvey, and thank you, PeerView, for having me today in this great panel of oncologists and friends as well. Immunotherapy is not yet a standard of care for patients with HR-positive, HER2-negative breast cancer. This is a less immunogenic subtype within breast cancer. But we are starting having some very interesting data that are suggesting us that potentially we could have the incorporation of immunotherapy in this subset of patients in the future. But let's start by discussing the Keynote 756 study. This is a perioperative trial, like the Keynote 522 trial in triple-negative breast cancer, which included patients with CT1C, CT2, CN1, 2, or CT3 with whichever nodal involvement, centrally confirmed ER, HER2, and grade 3, treatment naive, of course, with the stratification factors being PD-L1 status, nodal status, and also the positivity of ER. The trial randomized patients to receive either chemotherapy with paclitaxel, followed by anthracyclines and cyclophosphamide, either with pembrolizumab in the experimental arm or with placebo in the control arm. Then patients underwent surgery, and as adjuvant treatment, they received either pembro if they received pembro in the neoadjuvant phase, or placebo if they received placebo in the neoadjuvant phase, in both arms in combination with endocrine treatment up to 10 years. This was endocrine treatment as per investigator decision, but did not include CDK4/6 inhibitors. The dual primary endpoints were PCR and event-free survival. Just to take a look at the characteristics, the main characteristics of patients included in the trial, I want to highlight here that the vast majority of patients included, 80%, had a PD-L1 positive tumor with a CPS of at least 1. Less than 1/3 of these patients received dose-dense anthracyclines, which is something that we cannot usually do in the triple-negative subtype. And 90% of the patients had a positive nodal involvement. I mentioned before that the patients could have been eligible even with a ER positivity between 1 and 9%, but these are the ER low tumors. We'll talk about this in a while, but the vast majority of patients, 95% of patients, had a true ER positive tumor with ER of at least 10%. The primary endpoint of progression of pathological complete response was met with a delta of 8.5% with the addition of pembrolizumab to chemotherapy, which is quite interesting. Basically, this is the final delta that we have seen in terms of PCR with the Keynote 522 trial for patients with triple-negative breast cancer. But and this is consistent across subtypes, across subgroups, also for patients with ER positive tumors, more than 10%, which was the vast majority of patients, as I mentioned before. But the other data confirming the validity of the primary endpoint were the secondary endpoints looking at other PCR definitions, which were encouraging as well by demonstrating this pembrolizumab benefit when added to chemotherapy. And this was pretty much consistent by disease stage, because pembrolizumab improved the benefit over chemotherapy in both stage 2 and stage 3 disease, with a pretty consistent delta of 9% in stage 2 and 8% in stage 3. When we look at the PCR by nodal involvement, we start getting a first indication on which would be the ideal population suitable to receive neoadjuvant pembrolizumab in case of HR-positive, HER2-negative disease, because we see the the greatest benefit in patients with nodal involvement. Here the delta is 9.3%, while we have less than 4% in patients with node-negative disease, although this was a minority of patients included in the trial. Probably one of the most important finding is in this slide, because we can clearly see how in the HR-positive, HER2-negative subtype within the KEYNOTE-756 trial, the benefit by adding pembrolizumab to chemotherapy in terms of PCR is more evident in patients with PD-L1 positive tumors, starting with a CPS of at least 1, but with an increasing benefit with increasing cutoffs of CPS. And also, we can see here a benefit, which is mainly in patients with PD-L1 positive tumors, both in the group of patients with ER below 10% and in patients with ER positive, so with at least 10% of tumors, with a different magnitude of the benefit by adding pembrolizumab. As you can clearly see here, we have a delta of 24% in patients with ER below 10%, but these are patients that we should consider patients with ER low tumors, so with a behavior more likely to patients with triple negative breast cancer rather than patients with HR positive, HER2 negative tumors. There is also another trial which is very similar to the KEYNOTE-756 trial. This is the CheckMate 7F trial, which included patients with newly diagnosed ER positive, HER2 negative breast cancer, also confirmed ER positivity, same stage criteria for being included, T1 CT2 with positive nodal involvement, or from T3 with any nodal status. Here, patients could have been included if grade 3 with ER of at least 1%, or also ER low tumors with grade 2 tumors, and stratification factors were PD-L1 status again, tumor grade, axillary nodal status, and frequency of anthracyclines. Pretty same backbone chemotherapy backbone, but with different immune checkpoint inhibitor, which was nivolumab. Also a perioperative trial with the nivolumab given with the chemotherapy in the experimental arm as neoadjuvant treatment, while there was nivolumab placebo for nivolumab with chemotherapy in the control arm. Then patients underwent surgery, and in the adjuvant phase they could have received either nivolumab or placebo, continuing what they received in the neoadjuvant phase. Just to mention here that differently from the KEYNOTE-756 trial, where we are waiting for event-free survival data, this trial has been amended, so we will just have PCR data here. We will not have event-free survival data from this trial, because it was amended, given the possibility in the adjuvant setting to have whichever endocrine treatment, potentially also with CDK4/6 inhibitors, which became a standard of care in this subset of patients throughout the conduct of this trial. Slightly different patient characteristics in this trial, because here 2/3 of the patients had a PD-L1 negative tumor, while 1/3 of the patients had PD-L1 positive tumor. Also in this case, the vast majority of patients, 80% had positive nodal involvement, while 20% of these patients had no nodal involvement. It's interesting to see the results here from this trial, because we have a delta of 10% in the intent to treat population, looking at the different benefit of chemotherapy plus or minus nivolumab, with a benefit when nivolumab was added to neoadjuvant chemotherapy in the intent to treat population in terms of PCR, but it's even more interesting to look at the data of PCR by PD-L1 status, because we can clearly see here that the most evident benefit by adding nivolumab is in patients with PD-L1 positive tumors. We we have a 20% PCR rate for patients with placebo, and 44.3% for patients with chemotherapy and nivolumab. So in a subset of patients, in a subgroup of patients with HR positive, HER2 negative breast cancer, where we have a very low PCR rate without immunotherapy, this 20%, we can get 24% more of PCR when we add nivolumab, which is very interesting, but this highlights the need for a better patient selection in this subset of patients. You can see here in the forest plot that the benefit by adding nivolumab to chemotherapy was more evident in patients with PD-L1 positivity by SP142. But there are some very interesting translational studies that have been presented by the investigators trying to identify the patient population more likely to derive a benefit from the addition of nivolumab to chemotherapy. Javi told us that in the triple-negative breast cancer, the immunotherapy benefit comes regardless of the PD-L1 expression, while it's not the case here in the luminal subgroup. Here, investigators evaluated the concordance between PD-L1 assays by SP142, which was used because it was the one typically used in breast cancer, and 28 CPS with DACO test, which is the companion diagnostic for nivolumab actually. And what we can see here is that there is a higher concordance rate with SP142 of at least 1% and 28 CPS of at least 3, with less concordance for higher rates of CPS cutoffs. We already mentioned that there is an overall benefit in the ITT population with increased benefit where PD-L1 is positive, but also in this case we can gain further insights on the potential patient population more likely to derive a benefit from immunotherapy in the neoadjuvant setting in case of ER-positive, HER2-negative tumors. Basically, the optimal cutoff for the prediction of nivolumab benefit in this study was seen for a CPS of at least 3, and the benefit of nivolumab was increased in those patients who could be defined PD-L1 positive by both SP142 assay and 28 CPS assay, with greater benefit for increased CPS score. But also, if we wanted to add some more biomarkers that could help us identifying those patients more likely to derive a benefit, investigators also looked at stromal TILs by seeing that there is a greater nivolumab benefit in terms of PCR rates for patients with stromal TILs at least 1% cutoff. And also, if we combine a PD-L1 positive tumor by SP142, and there is also a stromal TILs, there is also TILs presented in the tumor, we may have an even higher probability of achieving a PCR. So combining different biomarkers in this subgroup of patients could be key to identify those patients more likely to derive a benefit from immunotherapy. But also some other biomarkers, ER and PGR. These are very classical biomarkers for ER-positive, HER2-negative tumors, of course. But here, the investigators have shown that the greater nivolumab benefit in terms of PCR is seen in patients with tumors with lower expression of ER, with a cutoff by defining lower of 50% in patients with low progesterone receptor expression below 10%, while they couldn't see any differences by Ki-67. I mentioned before during the presentation of these 2 very important trials who brought at least the possibility of considering immunotherapy in patients with HR-positive, HER2-negative tumors. The fact that we need to deal with some patients with ER low tumors. We know that ASCO-CAP recommend ER below 1% to define triple negative breast cancer, but actually we have the so-called ER low breast cancers with a ER expression between 1% and 10%, which is a quite rare subtype, but we are talking about less than 10% of triple negative breast cancer patients and 5% of patients with ER positive tumors. And we know that the pathological features as well as the outcomes of these patients with ER low tumors are more similar to patients with triple negative breast cancer as compared to patients with HR positive HER2 negative tumors. So we need to know how to treat these patients in the clinical setting. We have published this year some data with the Padua group demonstrating that in patients with ER low tumors and in patients with triple negative breast cancers, there is the same density of tumor infiltrating lymphocytes and also the same rate of PD-L1 expression and CD8 FOXP3 ratio for patients with ER low tumors and triple negative breast cancers. And also these have been demonstrated to be prognostic in both triple negative breast cancer and ER low tumors in this paper we have published this year. So in this context, I think that we have a very biologic rationale to conclude that triple negative breast cancer patients and patients with ER low tumors should be treated the same way, but this is not possible everywhere. For instance, in Italy, we cannot treat these patients as patients with triple negative breast cancer. But at the latest ESMO meeting, a French real-world study, the Promenade study, explored the use of the KEYNOTE-522 regimen in the real-world population of patients with ER-low tumors. And actually, as you can see here, we have 75% PCR rate for the Promenade, which is in line with the rate of PCR rate that we have observed in the KEYNOTE-522 trial and also in the ER-low portion of patients included in the KEYNOTE-756 trial. A bit slow, a bit smaller here, but just to remind you that the KEYNOTE-756 trial, which was designed for patients with HR positive HER2 negative tumors, did not include carboplatin, and Javi just demonstrated us that there is a rationale for including carboplatin in the backbone chemotherapy for patients with TNBC. So I think that we will also make a cultural shift to consider also patients with ER-low tumors as patients with triple negative breast cancer in order to offer them the best available treatment, which has also improved overall survival within the KEYNOTE-522 trial. Thank you.
Thank you, Carmen. Fantastic oversight over where we are in ER-positive breast cancer. And I think lots of fruit for discussion, which we are about to start now. So if we go back to triple negative breast cancer, where obviously immunotherapy is now standard of care. Question to both of you, and maybe Javi, you start. Are there any clinical groups, so defined by clinical parameters, within stage 2 and stage 3 triple negative breast cancer you wouldn't consider for immunotherapy?
Well, thanks, Peter, and great talk, Carmen, also. I agree with Peter. So, well, this is always a tricky question because clinical practice is much more difficult than clinical trials. In the clinical trial, you have to look at the inclusion and exclusion criteria, and that is it. So here, I think that we have taken into account, of course, important inflammatory aspects that patients might have had or comorbidities. I don't know, maybe extreme or very old patients. That's something, of course, to be considered, or patients with a very important, I don't know, lupus or psoriasis, something which is not very well controlled, because that's something that always have to be discussed, pros and cons. It's not the same to have a T2 and 0 that having maybe T3 and 3 or something like that. So I think that also another aspect important, in my opinion, is that inflammatory triple negative breast cancer was not included in KEYNOTE-522, but I certainly would consider if I have a patient with that disease. I think that, again, clinical practice is much more difficult, but for the great majority of my patients, I always consider immunotherapy.
But if I put words in your mouth, you would say based on clinical parameters, the tumor size, stage, so you would consider practically all patients for immunotherapy. unless there's an exclusion criterion in terms of safety concerns around, for example, autoimmune disorders. Would you agree with that, Carmen?
Yeah, sure. I think that this has to be considered the optimal treatment for all our patients who met the eligibility criteria to receive this treatment unless they have a contraindication to immunotherapy. And I consider not ethical not offering this treatment if a patient meets the eligibility criteria, just for the sake of the discussion, so not for clinical practice. I think that it would be interesting to know who are those patients in the control arm of the Keynote 522 trial who do not have events at 5 years. It's 72% of the patients not receiving immunotherapy and not having events at 5 years. So it would be interesting to understand who are those patients, but since we cannot identify these patients in clinical practice, it's important to offer pembrolizumab to all our patients.
And I think that brings us to a question and almost a dilemma we have been having, not just in triple-negative breast cancer, but also across all subtypes when we want to give chemotherapy as well. As can we identify those patients reliably who are cured without chemotherapy or who are cured as a result of chemotherapy? And here now the add-on question, who are cured as a result of the addition of immune therapy. You both spoke up quite a bit about biomarkers. What's your take? So are we able, I mean, we saw the biomarker discussion in San Antonio, but is there anything we can actually take out from there and say, can I pick one or two biomarkers and choose a group of patients where I wouldn't give immune therapy, or where I would say they definitely have to have immune therapy? Or is it just the same as we see with clinical parameters? We see maybe slightly more, slightly less benefit, but ultimately we haven't got a black and white biomarker that allows us to de-escalate or escalate.
Maybe two comments here. The first one is about PD-L1. PD-L1, unfortunately, I don't know the reason why, it is still, at least in Spain, it is asked for PD-L1 for many, many patients. And in early perioperative breast cancer does not play any role. But just to make that comment that we shouldn't ask for PD-L1 to make the decision. So I think your question is terrific, Peter. So can we identify now patients to select pembrolizumab, yes or no? In my opinion, we would love, for example, a tumor with a lot of tumor-infiltrating lymphocytes, maybe, but I would put the word maybe. But of course, I think that we do not have data enough to select the use of pembrolizumab. I think that we should work in prospective data, adding biomarkers to be considered. Because if not, it will be very, very difficult to select who are those patients who will need or will not need some drug that has clearly improved survival. So in my opinion, we shouldn't do it, but of course, we would love it.
And talking about the TIL data you mentioned, and Carmen presented them for the ER-positive study. Again, my simplistic take is if you have more TILs, you have a better response to chemotherapy. We've known this for many, many years, but actually the additional benefit of immune therapy is still present. Or would you interpret this differently, Carmen, for the ER-positive study?
I think it's different from for the ER-positive studies, because I think that in the HR-positive, HER2-negative subgroup, we should be selecting patients potentially benefiting from the addition of immunotherapy by including more parameters to me. So PD-L1, just to start, but also ER degree, PR degree, and TILs. In triple-negative breast, so more parameters to select those patients potentially benefiting from the addition of immunotherapy, in addition to clinical parameters, of course. In the triple-negative breast cancer subtype, I think that at the time being, we do not have reliable enough biomarkers to safely omit pembrolizumab in these patients. So I think that at the time being, at least, we should be offering pembrolizumab to all patients with eligibility criteria. Of course, in terms of research, it would be interesting to understand whether with an immunogram or with an immunoscore, combining different aspects, we could be able to identify those patients who could safely de-escalate pembrolizumab, but it's something that we cannot do nowadays in clinical practice.
Can we spend 2 minutes on safety of the IO regimens and then move on to ER-positive breast cancer to wrap it up? So how do you find it in real-term practice managing patients on chemotherapy and immune therapy? Is it more intense than what we used to do with chemotherapy? How have your teams adapted to this? How do you oversee the possible immune-related adverse events?
Point here is to know that this might happen. We should not forget that this is an adverse event that might happen and happens sometimes. It is true that the great majority of events are grade 1 or grade 2, and in grade 3 basically are hypo or hyperthyroidism. So the most severe adverse events are very rare. I'm talking nephritis or myositis or pericarditis. They are very, very rare adverse events that might happen, and it should be important to diagnose early on time to treat it properly. But I think that in general, adding pembrolizumab do not increase the adverse events as a whole. So I think that, again, we need to know the adverse events. We need to manage the adverse events. We have to work with other specialties, but as you have said many times, Peter, and I couldn't agree more with you, we should be the leaders of the patient care, and we should be helped with others, but we should not give the patient care to others, even if pneumonitis or some of these adverse events might happen. I think that we should take care of these patients.
I think it's a really important point. I think as the oncology team, we need to be in the driving seat when it comes to recognizing and managing immune-mediated side effects. Because if you start referring those patients out, there's already a delay until those patients are started on therapy. For example, pneumonitis, but also hepatitis. These are rare cases, but I think we need to initiate our therapy very early on, and then it's relatively well manageable. Can we just switch to ER-positive disease for the last few minutes before we...
Let me make a quick comment, Peter. Sorry for interrupting you. It's important to remember that Rebecca then presented 2 years ago some data of the patient-reported outcomes, the quality of life. We observed that there was not differences at all between both treatment arms. So at the end, even with these adverse events, patients reported very similar quality of life, which I think is important also.
Yeah, it's a really, really important point. And thank you for emphasizing this, Javi. Now, ER-positive breast cancer. Carmen, you quite rightly pointed out, this is probably not going to be a strategy for every single patient. And in ER-positive breast cancer, we have very different populations. So we got in the classic ways looking from a hormone sensitivity point of view, luminal A versus luminal B. And we probably have something similar when it comes to immune therapy, a group of patients where the tumor biology will allow us to induce immune therapy, in a group of patients where it doesn't. Now, the trials you presented were obviously pre-selecting for patients who are probably a little bit more luminal B cancers.
I think that first of all, we need to understand if based on the event-free survival data of the KEYNOTE-756 trial, immunotherapy will become an option for our patients with ER-positive, HER2-negative tumors in the neoadjuvant setting, and if it will be implemented by guidelines. But should it become an option, I think that we will have to highly select patients for immunotherapy, because the benefit we have been seeing is completely different as the one observed for patients with triple-negative breast cancer. So I think that we will need selection based on stage, grade 3. So stage, nodal involvement to me, grade 3, but also lower ER and PR expression, as we have seen from the data I presented from the CheckMate trial, as well as PD-L1 expression, of course, stromal TILs. So I think that we will need a score incorporating all these elements to identify those patients more likely to derive a benefit here, because it's a different setting.
Yeah. And I think the obviously we will need to wait for event-free survival data. And I think then the whole picture will become clearer, which groups benefit or not. For example, I found interesting what you shared around PathCR rates, patient no positive, no negative disease. Now, interestingly enough, when we did these analyses at Keynote 522, initially looking at PathCR, there was a suggestion that patients with no positive disease benefit more than patients with no negative disease. And again, interestingly enough, patients with no positive disease usually have lower PathCR rates compared to patients with no negative disease. But when we added in immune therapy in 522, and actually the same was seen in Impassion 031, the PathCR rates were identical for patients with no positive or no negative disease as long as immune therapy was added. However, all of that went out of the window when we looked at event-free survival. And the event-free survival benefit was identical, practically no negative and no positive disease. So with PathCR and no positivity, I think we just need to wait for the event-free survival data. We're going to just go to a subgroup where we may already look at these data as practice enabling, maybe is a nice word in this context. What about the ER low patients, Javi? You spoke about them earlier. What do you do with them now in clinical practice if you get away with it?
I was thinking about this group of patients. I think that these patients behave very similarly to triple-negative breast cancer. From the biological perspective, it is basically identical. So I was thinking that yesterday I was treating these patients with pembrolizumab because, again, I think they are very similar. Today, we have this data that at the end, we have some support that give us the opportunity to have some press data saying that, listen, this is something that you can do because you have the data here. So in my opinion, ER low should be treated with triple-negative breast cancer, that's my opinion, adding carboplatin as well.
Now, if you say ER low, that obviously suggests their whole tumor is ER low, but in reality, in that group, for example, with an IRED score of 3, you got 90% of the tumor is triple negative, or more than 90%, and there's a small fraction ER positive. Now, so my argument, exactly as you said, is this is a triple-negative breast cancer, possibly with a small ER-positive clone, rather than a mix of tumors that is ER-low, and therefore I would give immunotherapy. But what do you do with platinum?
Give platinum compounds, nothing to lose. Again, I think that the biology is very similar. We do not have strong arguments, that's true. But if the biology is similar, the prognosis is similar, these patients usually do not respond to endocrine treatment in the metastatic setting. We have the data coming from ASCO showing that in the adjuvant setting, maybe these patients should be offered endocrine treatment. So I would combine with carboplatin. If PCR, I will continue with pembro with no endocrine treatment. If no PCR, I would love to see the estrogen receptor status to consider adding endocrine treatment as well, in addition to pembrolizumab. That's how I treat these patients.
Javi, thank you. It has always been great fun, very informative for me, and a real joy having this hour with you. The hour is unfortunately up, where we have to wrap it up. I hope you enjoyed the program. For me, very clear the takeaways. Immune therapy it is standard of care in a neoadjuvant setting when combined with chemotherapy for stage 2 and stage 3 triple-negative breast cancer. Stage 1, we haven't got data to suggest this. Important is the way immune therapy is given with the right chemotherapy regimen, as we said, because the impact of the chemotherapy regimen may change the results, as we saw in some studies. And also it is critical that we give it in a neoadjuvant setting, not in a postoperative setting to start, because if the tumor isn't around anymore, we can't launch the immune response as well. Positive data, there's a lot of similarity in the early data, obviously with a very different biology to what we saw very early on in terms of PathCR data in triple-negative breast cancer. There's clearly a group of patients where many of us feel we would like to do this already in ER-low patients. But I think for patients who are not ER-low, we will have to wait for event-free survival data. But many of us are confident and very hopeful that this will also be practice-changing over time. Thank you once again for both of you for making this happen today, for PeerView for putting this program together, for all of you for dialing in, and I look forward to catching up soon. Thank you very much.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/HKW860.